medical assistance in dying or MAID, that it would no longer be offered to people who are dying, but would include those who are chronically ill and disabled as well. And so we have a panel of speakers who are going to talk today. It's going to be primarily Dr. Coella, who's going to be running it. And then we have three other speakers who are going to speak. Dr. Coella is a London-based family doc who cares for disabled and marginalized populations, very interested in this topic. We also have from Queen's University, Dr. Leonie Herx, who's associate professor and chair of the Division of Palliative Care at Queen's University. We have as well Gabrielle Peters, who I actually was looking at her Maclean's article, and she is described as a disabled woman living on one of the country's lowest incomes in one of the world's most expensive cities. She comes from Vancouver. And then Dr. Valerie Schultz as well, who many of you know, who's an associate dean at Schulich School of Medicine. So we'll get started. And Ramona, you have the table, and thank you for coming.
Thank you very much. And thank you for the introduction. I'm just going to switch slides here. Okay, so no conflict of interest that any of us can share today. Our learning objectives, we're going to look at the current legislation of C14, so medical assistance in dying in Canada now, and explore not necessarily the ethics of medical assistance in dying, but actually just the proposed legislation and what it will mean for medical practice, including physiatry. And then Gabrielle will explore the impacts of this bill on the disability community and other vulnerable populations. I'm going to turn it over to Dr. Schultz.
Good morning, and thank you very much for this opportunity. I'm going to start with some background information. So
can you speak up?
Sure. Is this any better? Let me just increase the volume there. Is that better?
Much better, much better.
All right. So I am going to talk about the background information and starting with some definitions. Where does euthanasia, assisted suicide, and MAID? Where euthanasia is the death intentionally caused by a lethal dose of a drug, and where the nurse practitioner and the physician directly administer that drug via an intravenous route. Assisted suicide is where a physician or nurse practitioner writes a prescription and the patient takes that medication themselves. MAID was a language developed in Canada. Medical assistance in dying was developed in Canada to sort of sanitize that language because that felt sort of harsh, and but however, it is exactly the same definition. MAID is both assisted suicide and euthanasia. Why do people ask for MAID? Research has been done to study this question. Although MAID was brought into place for the assistance of controlling uncontrolled symptoms such as pain, that is not the primary reason that MAID is chosen by patients. Primarily, it's for existential suffering, perceived loss of control or autonomy, perceived loss of dignity, meaning, purpose, and value in life, fear of being a burden to others, or fear of dying, or fear of pain, but not actually those symptoms themselves. MAID criteria, or access to MAID, is set by legislation, not medicine. So, and this is important for you to know as we go forward, MAID is based on changes to the criminal code and legislation, does not have its origins in healthcare. The law changes the criteria for access to MAID. And these changes to the criteria in the law are based on exceptional cases. Healthcare, or medical care, in contrast, is driven by medical research and medical evidence. Therefore, access to certain medical care is dependent on a balance of risk versus harms and benefits, and an average, who on average benefits from healthcare will receive that type of healthcare. So completely different. One's based on exceptions, one's based on averages. And what's an example? So here's an example of how that matters. Bone marrow transplant and high-dose chemotherapy for significant metastatic breast cancer became promoted by public interest because patients felt that this may be beneficial, and it was not covered by healthcare coverage. So they went to court to have it covered, and it was based on these exceptions. People wanted that type of care covered by our medical insurance. And it was then studied in medical practice, and it was demonstrated there was no benefit to patients, and their harm actually may outweigh the benefit of having these a bone marrow transplant for metastatic cancer. And because its roots were in medical practice, medicine was able to stop the practice and adjust its cancer care for this patient population. The progression of the Canadian legislation around MAID started it started years and years before 2015, but prior to 2015, no one could consent to being killed by another person. In 2015, Carter versus Canada was held at the Supreme Court of Canada, and they struck down the criminal prohibition on homicide for the purposes of MAID, which is euthanasia, and assisting in suicide for the purposes of MAID. In 2016, then Bill C-14, medical assistance in dying, came into practice, and that was actually June 17th, and that legislation came out of the Government of Canada. In 2020 and now 2021, Bill C-7 is currently before the Senate. You will hear a lot more about Bill C-7 this morning. And what you need to know is that there are future considerations beyond Bill C-7. In 2021, there will be conversations regarding access about mature minors, mental health, and advanced directives. How often is MAID provided in Canada? Approximately 20,000 MAID deaths have been reported as of the end of 2020. The case numbers increase steadily each year, and currently there's just over an average of 200 cases a month for MAID in Ontario. This is approximately 2% of the deaths with regional variation.
Okay, thank you very much, Dr. Schultz. Dr. Perks will take over now.
Good morning, everybody. I'm going to review some of the current criteria for MAID and some of the safeguards that are in place under Bill C-14, which is our current legislations that guide MAID in Canada right now until C-7. So to be eligible for MAID under Bill C-14, you have to be eligible for publicly funded healthcare services in Canada, at least 18 years of age, and be able to make your own healthcare decisions. You must have a grievous and irremediable medical condition, which can include an illness, disease, or disability, and we'll come back to that language in a few minutes. And your death must be reasonably foreseeable. I've bolded that one as well because we're going to speak a bit more about it. You must make a voluntary request for MAID, and you must provide informed consent. There's been some discussion in the medical legal literature around, in the context of MAID, what includes informed consent. Under the Canadian legislation, you're only required to be provided information about your other options for care alongside MAID. So for example, what disability support services might be available, or what palliative care might be available. And some of the discussion has been around, is it simply enough to have information on your other options? Or do you actually need to have tried other options, or have other options for care at least accessible? And in some other countries, such as Australia, the Victoria, Australia legislation actually requires MAID to be a last resort after other treatments to alleviate suffering have been tried. And currently that's not the case under the Canadian legislation. Next slide, please. So the Supreme Court of Canada, in their Carter ruling, recommended that a robust system of safeguards would be put in place to minimize harm and prevent wrongful death to vulnerable persons. And under the C-14 legislation, and a few additional safeguards were added, along with, of course, having to meet the eligibility criteria. That is, that capacity of the patient must be present both at the time of a request for MAID as well again at the time for the procedure. There needs to be a 10-day reflection period. So from time of request, a minimum of 10 days must pass before the procedure is administered. And that gives patients a chance to change their minds. And we know from the palliative care literature that often, as Dr. Schultz has suggested, a request for hastened death can be an expression of grief or anger, and not necessarily that they are requesting a lethal injection. And so having a period of reflection, because many people do change their minds, and that's our lived experience in palliative care, and the literature speaks to that, was put in place so that people do have that opportunity to reflect. Monitoring requirements, I'm going to speak a bit more around that shortly, to oversee the system of MAID in Canada, and that would be part of a 5-year parliamentary review. That there would be 2 independent assessors who determined that the patient meets the eligibility criteria for MAID, and as well 2 independent witnesses to minimize the risk of coercion. So I'll just briefly speak to each of these safeguards. First, I'll start with the monitoring requirements. So until November 2018, there was no standardized system in place for monitoring of MAID in Canada. Provinces were collecting different types of data. But then in 2018, a system of basic demographic information was instituted by Health Canada. It is important to note that many factors that have been identified as making people vulnerable to MAID, such as socioeconomic status, race, level of education, language abilities, are not being collected or even asked about through the Canadian MAID data collection system. And the information that's collected is only reviewed in retrospect, not in real time. So there's no system if a red flag is raised where it would halt the process once it's started, other than the subjective views of the individual MAID practitioner. So there's no oversight body that will in real time be monitoring that all the criteria are being met. In fact, the Health Canada system is really that societal level basic demographic information portal. And it's actually left to the provinces, because healthcare is under provincial jurisdiction, to ensure that the regulations for MAID are being followed. And what has caused, I think, somewhat of a gap in our system in Canada is that as you've heard from Dr. Schultz, MAID is actually a criminal code exemption. And so there's some uncertainty as to if there are concerns around compliance. Who do you speak to? Is it provincial healthcare? Is it the regulatory colleges? Or is it, because it's criminal code, is it actually the police, for example? From an eligibility criteria perspective, there's been concern raised around the ambiguous language that's open to broad interpretation, both by the regulatory bodies as well as courts. So the CPSO has said that the term grievous and irremediable is not consistent with clinical terminology and can be difficult for physicians to objectively determine what that means. The term reasonably foreseeable death has been challenged and overturned in the Superior Court system in Ontario. And the judge in that ruling, which has now set the precedent for future cases, has said that there's no specific requirement for a prognosis or a timeline when it comes to reasonably foreseeable death. And we can see in that court ruling that a woman, patient AB, who had osteoarthritis that was causing her grievous and irremediable suffering, became eligible for MAID based on age alone. She was 77 years of age. Concern has been raised in the medical literature around the independent nature of the assessors. So in Quebec, there is an end-of-life care commission who reviews all MAID cases at a provincial level. It's the only province in the country who does have a system in place for review retrospectively of all of the MAID data. And that end-of-life care commission has noted that there was concern about the MAID assessors being independent. Other reports have suggested that it's a small community of practitioners, and so many of the assessors know each other. And in addition, the reports are not blinded, so the second MAID assessor can see the first MAID assessor's assessment. There's also no limit to the number of assessments that a person can get. You just simply need to get 2 different assessors who approve you. So there's a recent case in the Nova Scotia media where a man had gone and gotten 7 different MAID assessments until he was determined eligible by 2. And so that has caused some concern around eligibility as well. I'll talk a little bit about the 10-day reflection period. So what we do know from some reports out of Quebec as well is that up to 60% of MAID cases have the 10-day reflection period waived. And there are only 2 rules under the criminal code criteria that allow for that to be waived. One is imminent death or imminent loss of capacity. And of those cases in Quebec that were waived, almost half of them didn't meet the criminal code criteria for removing of that waiting period. And of those, a quarter didn't have a documented reason for removing it. So we do have evidence in the literature that suggests that some of these safeguards are not working, but we have not had a robust evaluation at a national level, in part due to this discrepancy in who's overseeing MAID, to make sure that the current safeguards under C14 are indeed working and providing safety to protect vulnerable persons. Next slide, please. Dr. Jaro Kodelik, who's an ethicist at Lakehead University in Thunder Bay, has done a recent publication in December of 2020 that really looked in detail, and I encourage you to read his paper if you're interested, around the challenges of monitoring the Canadian MAID program because of these gaps that I've just explained. So while there are concerns documented on local levels, there's no really robust evidence to show that the system is working at the national level, which should be part of that 5-year parliamentary review. I've mentioned some of the concerns around adherence to safeguards, such as the 10-day waiving of the 10-day waiting period. And there's a lot more details. We don't have time to talk. We could actually spend a whole hour just talking today about the safeguards, but that's not the purpose of this talk. It was more to give you a flavor that we don't know that we're doing this well currently under C14. But in a paper that I wrote with some colleagues in the World Medical Journal, published in April 2020, there's a lot of detail and very thorough review of all of the different safeguards and the evidence from the literature of concern. As I've explained, there's not really a clear system of oversight because of this discrepancy between the criminal code, provincial regulatory bodies overseeing physicians. And so if there are causes for concern or complaints, it's not clear who to direct those to. And very importantly, there's no protection for whistleblowers in the legislation. Finally, a number of concerns have been documented in the very limited reports we have from the provincial level. So I've mentioned already the Quebec End of Life Care Commission. Every year they publish a report, and each year since legalization in Quebec in 2015, there have been reports of compliance concerns. The Chief Coroner of Ontario collects additional information outside of the Health Canada reporting requirements, and they have noted both compliance concerns with the criminal code as well as provincial regulatory body rules. And the BC Coroner Service, only one report was issued by them in 2017, and they also noted that up to 40% of cases did not have all of the reports filled in correctly, and so there's missing data. If you could just go to the next slide, I'm just going to give you one example of the type of reports that we've seen. This is the last one from the Office of the Chief Coroner of Ontario, and we haven't seen any further reports since, but in this one in 2018, I've highlighted here that they demonstrated compliance concerns with both the criminal code and the regulatory body policy, some of which have recurred over time. However, to date in Canada, no doctors have been charged regarding compliance with MAID. So that's the current state of C14. Thank you.
Thank you, Dr. Hurst. Okay, I'm going to take over now, and I'm going to start at where, like, in terms of the current situation in terms of Bill C7. As Dr. Schultz shared with us, this is about legislation that will have medical implications and legal challenges changing eligibility criteria. And this is what happened. In 2019, Truchon and Gladue challenged the lower court in Quebec. Truchon was a quadriplegic with cerebral palsy. Gladue has post-polio syndrome, and so they didn't qualify to receive medical assistance in dying. The court ruled in their favor and struck down the need to be dying to access medical assistance in dying. And the federal government surprisingly did not appeal this decision. That's very unusual. And then the court proceeded to give them a deadline of 6 months to change their law. That was in February of 2020 that they introduced it, and it's been extended through court extensions to February 26, 2021. So Bill C7 is currently before the Senate. It has passed the House, and so it's still being debated. Truchon himself, a recent Globe and Mail article outlined his fate. He decided to choose an early death through medical assistance in dying, saying that COVID-19 had forced him because he was isolated in a long-term care center. And he said, "The coronavirus has literally stolen my time with those I love." In terms of Bill C7, as it stands in summary, there are two proposed tracks. There's track 1 for those who are dying. So the eligibility and safeguards that Dr. Hertz described. There's a new track, so they're following that C14, but they're amending it to change the safeguards, and we'll talk about that. And there's the new track for those who are not dying with chronic illness and disability. Just to clarify, because I think it's helpful, because many people ask, mental health, if it's your sole criterion, so if you're just depressed, you cannot receive medical assistance in dying, you're not eligible. However, if you're depressed and have rheumatism or fibromyalgia or some sort of chronic illness or disability, then you do meet the eligibility criteria. In terms of track 1, you can see that those safeguards that Carter had suggested and were enacted in C14 are being dismantled. And they're being dismantled with actually no studies proving that they were working or not working. And in fact, there's a lot of case studies that say that they probably weren't stringent enough. But you no longer need 2 independent witnesses, and actually you only need 1 witness, and that witness can be a hired paid caregiver as a reasonably foreseeable death, which is said in Carter needed to protect vulnerable groups, has been struck down. No 10-day reflection period if you are dying, meaning that the same day that you request MAID, you can receive it. I'd like to quote Jean Marmorio, Dr. Jean Marmorio. She is one of the founding members of the Canadian Association of MAID Assessors and Providers, and she's a medical advisor to Dying with Dignity. So clearly she is a proponent, she supports medical assistance in dying in principle. And so she comments, on only 1 witness. Right now, neither of the 2 people who witness your request for MAID can benefit in any way from your death or be involved with your direct care. But with just 1 independent witness needed to sign, there's a greater chance of abuse or mistakes. For conclusion, let's keep 2 witnesses. On waiving the 10-day reflection period, the obvious danger here is that your last act will be impulsive. Under C7, I'll be canvassing more specialists because with the loosening of the criteria for medical assistance in dying comes the risk of making a terrible mistake. And then now I'm going to talk about the second track, which I think will affect you more than track 1. But track 2, for those who are not dying, basically includes on the left side the eligibility criteria and then what needs to be done. So you need 2 MAID assessors, 90 days from first assessment to be able to access that lethal injection. There's nothing in the legislation that says it has to be after care has been tried. And that's been something that's been brought up over and over again, this concern that as opposed to legislation internationally where care should be tried, and especially when you're not dying, that care must be tried. That is not actually in this bill. 1 expert needs to be involved. It's not clear if it's just a phone call or an actual consult at what level. And the patient needs to be informed and offered treatment options. In terms of the criteria, as Leonie talked about in that court case, serious and incurable, chronic and irremediable is been basically shown through the courts to be anything, because as a subjective thing, hence osteoarthritis qualifies for this, as will all of your patients and the vast majority of my patients. I'm going to only talk about this, So just also to say, in terms of being offered treatments, there, like I said, there's no requirement that actually means have to be available for treatment. So in Canada, 70% of those dying do not have palliative care. The waiting time to see a psychiatrist, physiatrist, rheumatologist, pain clinics can be 4 to 8 times longer than the 90-day waiting period. Dr. Ethans, Karen, had already talked about this study in her PMR Canada presentation in December. So just to say that they've done this study that was started before this bill, and that wasn't the point of this study, where they followed patients with spinal cord injury over several years. And they interviewed 23 people with chronic spinal cord injury. And the majority said that at the beginning, when they realized they were paralyzed, they were suicidal. And despite this now, none of the participants would want to pursue MAID or end their lives, and all participants shared that they would not have been able, even though they thought they would have had the capacity to make that decision, they understand now, being out several years, that they would have not been able to make an informed decision about MAID early post-spinal cord injury. Dr. Ethans shares that many doctors who work in the emergency and intensive care settings can have a profound impact on her patients after injury when they are vulnerable. And these doctors sometimes do not have an informed idea about living with disability, and they may inaccurately present future outcomes. Dr. Ethans shared that most of her patients, when they have a new spinal cord injury, are suicidal, but after rehabilitation, integration into the community, most of them, after a few years, after 2 years, the vast majority rate their quality of life as the same as the non-disabled population, in fact, many higher. She says being offered death in the early period when they are vulnerable to failure to understand them, when they are vulnerable is a failure to understand medical evidence around injury and recovery. Just to share 2 amazing stories. So David Shannon, Canadian disability human rights lawyer, won the Order of Ontario or Order of Canada Human Rights Commissioner. He, in 1981, in a university rugby scrum, had an injury that left him quadriplegic. And he's gone on to do amazing things, right? He's also trekked across Canada in a motorized wheelchair, and he's the first person with to plant at the North Pole a wheelchair parking sign. So, but he shares, even though most of us can only dream of being like David, that his first years, months to years of his injury, he was very vulnerable. And Christine Cowley at the top had a spinal cord injury 33 years ago. She has a doctorate after that. She became a professor. She's a wheelchair champ, Paralympian, and she's married and has 3 children and traveled the world, all after her injury. But Chris shares that for the first 5 years, she didn't feel great often. And she had to go through rehab, vocational training, and reintegration into the community to feel healed. And she shares that if someone had offered her, or MAID had been legally available to her in her early years, she may not be here today. In terms of challenging all of our physician or just societal presumptions about disability, many people have mentioned to me that the reason spinal cord injury patients do so well, and I mean that this is true, is that they have a high quality of life, is because they're young and they have time to rehabilitate and return to work. And Dr. Ethans pointed out that the bias of acute care workers who have no proximity to disability can greatly underestimate these people's function and quality of life. But I think that this can even fail, these examples that I've given can fail to shake up our deep-seated ableist ideas. So ableism is this idea that people with able bodies are happier and more valuable than people with non-able bodies. And Gabrielle will speak more to this concept of ableism. But just to show, in terms of the medical literature, the stroke community, who are older and often not working post-stroke, have the same ratings as their age-matched healthy individuals of quality of life 2 to 3 years post-stroke. And what happens if we look at even more devastating stroke syndrome? If we look at locked-in syndrome, where you have damage to the pons. And it can also happen sometimes as chronic conditions like ALS, where someone has no voluntary control of their body, their cognition is intact, they can often communicate through blinking, they cannot make any sound. Often, people feel that this kind of life is intolerable, and we can even project that onto our patients. But similar to stroke, studies have looked at quality of life in survivors of locked-in syndrome. And locked-in syndrome patients often have the same range of quality of life as age-matched healthy individuals. The authors in the last study there, Rousseau et al., conclude, in opposition to a widespread opinion, locked-in syndrome persons report a satisfactory quality of life that stays stable over time, suggesting that life with locked-in syndrome is worth living. So just in conclusion to that medical point, that point about suicidality, that if we look at even myocardial infarction, it's not super relevant for physiatry, so just to brush on that, but chronic illness, neurological illness, all of these things, repeatedly in the literature, there is a timeline to resolution of suicidality, and it's more like 2 years, right? So Ethan's study points out that patients who have lived this experience wouldn't have had the capacity to truly understand their future. So they said, you know, even if someone sat down and explained, and we had mentors in some of the better programs, they had spinal cord mentors, we didn't really understand until we had actually lived that experience, and it wouldn't have been an informed choice. Another implication of this bill is that people are choosing medical assistance in dying due to inadequate care. And with this bill now being applied to people with just disability, they don't need to be dying. I perceive that just logically that will increase. I actually had a patient who talked to me on the phone a few weeks ago, and she told me that as soon as Bill C7 goes through, she might end her life because she's isolated, she's poor, she can't afford her disability supports after an accident. And she's very serious. So this isn't really about, like, those kinds of situations aren't really a free choice to die. They're desperate people who have like abysmal scenarios that they have to choose from. And you see Archie Rowland on the left. Archie is a landscape architect in Montreal who said that he was being treated inhumanely in his long-term care center, and he vowed to end his life. He ran away on July 4th, 2016, and 3 days later, he chose MAID. Raymond Bombonnet in the middle is also a gentleman who chose to die rather than live in long-term care. He reported his room was over 30 degrees in the summer. It's not uncommon in Montreal and some of our older centers. He had to leave his door open 24 hours a day if he wanted to access air conditioning, but then he had this incredible anxiety because people would just walk into his room, touch him, take his things, and he felt this was intolerable. Arlene Rainsborough on the right wrote to the Prime Minister, "It isn't depression that makes me want to die. It's the fear of living with inhumane, overcrowded conditions, loneliness, and lack of hope," she says. The homes she says she can afford are worse than living on the street or living at all. There's a recent study that was commissioned by the government in the Netherlands called the Netherlands Perspective Study. Like I said, the other jurisdictions that allow death, choosing death for if you're not dying, it has to be a last resort. A doctor actually has to sign that everything has been exhausted in terms of care. Not so in this proposed legislation. But the Netherlands government commissioned a study to see what would happen if they changed their legislation to be more permissive. And the study confirmed that when people are offered death, their choices are influenced by poverty, loneliness, unemployment, relation breakdown, and lack of home supports with their disability. That is, their disability has led to higher rates of social disadvantage that would lead to desperation, but not the disability itself. It is a societal failure to properly help these people that is actually driving their death wishes. And I shared in the Truchon case in Canada, he chose death because of COVID. So COVID disparity has made the COVID situation has made these issues worse and worsened like wealth disparity, limiting social support and increasing isolation for these populations. My last slide before I hand it off to Gabrielle is a step further, is people who have been offered MAID as a treatment option. Candice Lewis in the middle was hospitalized with an acute illness and has disabilities. And the doctor approached her mother and suggested that she receive medical assistance in dying. When Sheila said that she didn't want that, the doctor told her she was selfish and tried to convince Candice. And the family left the hospital because they didn't feel safe anymore getting care. Roger Foley, a gentleman who's hospitalized here in London, Ontario, captured on audio a medical administrator suggesting he take up the offer of medical assistance in dying, given how expensive his hospitalization was and that the government wouldn't fund his home care to live in community. Taylor Hyatt, a lovely lady with cerebral palsy, described her experience after being hospitalized with pneumonia, paraphrasing a National Post article. Hyatt said her doctor suggested the possibility of a medical assisted death instead of standard treatments of oxygen and IV antibiotics. All the doctor seemed to see was a disabled woman, alone, sick, tired, and presumably tired of living, Taylor shared. I would never want a medical professional to begin the conversation about life-ending initiatives as a result of assumptions they make about what it's like to live with my disability. Otherwise, I would not feel comfortable seeking certain forms of medical treatment. I want to be seen by a doctor who will care for me as a whole person, including taking my status as a disabled woman into account, and who will support me in living and thriving in the only life I have, which is as a disabled woman. Taylor's testimony raises two questions or two issues that are currently being debated in front of Senate. Firstly, some testified at Senate that they believe that medical practitioners should be raising medical assistance in dying with patients if and when they qualify. Coupled with that is our CPSO Ontario policy that demands we refer a patient to medical assistance in dying. This will put doctors in a position to have to facilitate medical assistance in dying for someone who has a treatable disease. Okay, I'm going to turn it over to Gabrielle.
Thank you for the opportunity to speak here today. I am here to speak to you about Bill C7, but before I offer any comments about the policy, I wanted to provide some very brief historical and theoretical foundation for them. But even before I do that, I'd like to introduce you to the disabled people you're currently looking at. The young Black woman wheelchair user is Sarah Juma. Sarah is one of the founders of the Disability Justice Network of Ontario, a leader in disability justice and community activism in Canada. Disability justice is a framework that differs from disability rights in a number of important ways, and two of the most notable are its emphasis on intersectionality and interdependence. Beside her is Vanessa Link, who is the creative production assistant for Rooted in Rights, a disability rights organization south of the border in Seattle. The two men who are smiling and working on a wheelchair, that is my wheelchair that they are in the process of repairing incidentally, are Hal Bennett and Clark Matthews. Clark Matthews is creative director for Rooted in Rights. Hal, on the other hand, is the type of person who can see a piece of adaptive gear or tech online and build it on his own. In the other photo, Hal is hugging Bronwyn Berg, his partner. Bronwyn is a writer and was speaking that day about applying a gender and disability lens to straight design as it relates to straight harassment of disabled women. Disabled women are approximately twice as likely to be victims of violence as non-disabled women, which makes it particularly striking that we have normalized strangers touching people's wheelchairs. Bronwyn shared the story of being out one day and man starting to push her in her wheelchair down the street, an event that is far too common in disabled people's lives. But this man was different and seemed intent on taking Bronwyn somewhere and picked up speed the more she yelled for him to stop. No one intervened even as she screamed for help. She managed to make enough of a scene that enough people stared. Still no intervention, and he let go and fled, running off between buildings to escape the police. which in fact no one had bothered to call. Bronwyn tried but could not seek safety inside a store because they had steps outside them, making them inaccessible to her. The two women standing together are sisters. Teresa Pockuk, who has Down syndrome, lives with her sister Franken and Franke's husband. The three have been together since they freed Teresa from a nursing home. Teresa and Franke were speaking together about accessible street design at the BC Active Transportation Summit where these photos were taken. Teresa and Franke are both artists, and Teresa is a published author of a children's book with a strong penchant for tie-dye shirts. I wanted to share these photos because they show disabled joy and CRIP camaraderie. CRIP is an abbreviation and reclaiming of the word cripple. In the disability community, we often talk about CRIP time, CRIP space, and CRIP pride. These photos were all taken in the Accessibility Room, a room I created as Director of Community Engagement, Inclusion and Accessibility. Initially, they were intended to address my concerns about the multiple accessibility barriers I was not able to mitigate in the brand new, and yet filled with accessibility barriers. Building it was held in what it actually became was a CRIP hangout spot, a place to gather and exist away from the abled gaze and intrusive questions by non-disabled people. In CRIP space, no one asks what happened to you or what is wrong with you. No one asks where the people who take care of you are. No one says, good for you for being outside. It was a place to just exist and to relax, to not be judged or queried. But as we know, separate is not equal. Next slide. I want to take you back in time for a moment. The disabled people in the previous photos live in the community, but that wasn't always the case. In fact, as I mentioned, Teresa used to live in a nursing home, though neither she nor her father, who she lived with, ever consented for her to be put in one. Teresa had lived her whole life with her parents, but after her mother's death, a relative had reported Teresa as in need of placement in a nursing home, despite her father still being willing to care for Teresa and Franke having made clear that Teresa could come live with her. With Franke's support, Teresa eventually won her legal right to live with her sister in 2014. Teresa's parents and her sister Franke never believed Teresa should be sent away, but many families did exactly that with their disabled family members, and more often than not it was at the urging of members of the medical profession. A university professor of mine shared that their family physician had urged him and his wife were urged to put their disabled son in an institution and forget he was born. For a time, that was what was considered good medical advice, just as MAID was recently offered to a woman now as a medical option while recovering from her disabling but non-life-threatening injury. The institutions were often located outside of the city in the countryside. The benefit of country air was part of the science. Next slide. Coincidentally, cities in the United States had passed ugly laws in the early 20th century barring disabled people from being seen in public. But I am sure sending us away to institutions in the countryside was for our good, not their convenience. The predecessor of the Canadian Mental Health Association created a poster in this slide. As the modern world was being built and its designs defined, we were sent away. The surplus humanity of surplus value is to be institutionalized, sterilized, and kept out of the way. We don't have time to discuss the full horrors and history of these places, but next slide. This is a photo of Urania, a former institution for disabled people in Ontario. This is the type of place where some of the people in the first slide might have been forced to exist. Let's not call it live in. Thousands of disabled people under the age of 65 and tens of thousands more over the age of 65 are still forced to live in smaller versions of these today. Next slide. This is a photo of life inside these institutions. Dorm rooms, identical clothing. What is not shown but is well documented is the sexual and physical abuse that went on in them. What is not shown is the loss to our communities. I have been reflecting lately on the identical clothing. I wonder sometimes how far we've really come from those gray sweatsuits. My friend and co-founder of Dignity Denied, Spring Haas, often talks about how personal support workers will complain that it is too time-consuming to help her put on skinny jeans, and wouldn't she just prefer to wear sweatpants? Next slide. This is a photo of the numbered grave markers that were dug up and used as paving stones for a path at the institution. In BC, the staff of an institution dug up the grave markers to make themselves a patio for barbecues. No one bothered to keep accurate records of the names that went with the numbers on those paving stones. Next slide. This is a photo of an out-of-use septic tank that was discovered in the middle of the cemetery around Huronia. We know all of this because of the justice work that was done, initiated by some of the institution's survivors, two of whom are pictured in this photo. Next slide. This slide is a work in progress. I am in the process of making a map of ableism, and this is a very rough draft. The Law Commission of Ontario defines ableism this way. Ableism may be defined as a belief system, analogous to racism, sexism, or ageism, that sees persons with disabilities as being less worthy of respect and consideration, less able to contribute and participate, or of less inherent value than others. Ableism may be conscious or unconscious, and may be embedded in institutions, systems, or the broader culture of a society. Ableist attitudes are often based on the view that disability is an anomaly to normalcy, rather than an inherent and expected variation in the human condition. It covers many important points, but it also misses the why. Ableism is systemic and embedded into all aspects of our society's structure, culture, language, and institutions. The Law Commission definition often leads people to think ableism is a matter of being nice or not nice to disabled people, and that the difference between those is a matter of awareness. This presumes that people's natural innate tendency is to be not nice and exclude disabled people. The idea is predicated on ableism being rational, logical, or perhaps an instinctive response to disability. In fact, nothing could be further from the truth. Researchers have discovered that ableism may be more modern than was first assumed. A number of recent discoveries challenge the idea that it was and ever shall be, including finding a disabled and deaf Neanderthal who had clearly been supported and cared for by others, a 4,000-year-old skeleton of a quadriplegic member of a Stone Age hunter and gatherer society who again would have needed and obviously received the care of his fellow humans, the existence of ramps in ancient Greece, and the 500-year-old burial of obviously well cared for Down syndrome child in Ireland. So what happened? Marta Russell wrote that, disability oppression has less to do with prejudicial attitudes than with an accountant's calculation of the present cost of production versus the potential benefits to the future rate of exploitation. We know that some religious traditions claim disability was a punishment or curse. The Age of Enlightenment, and the science it gave rise to, are portrayed as an end to these kinds of ideas. But while the thinkers of Enlightenment wanted to challenge some ideas, they used science to justify others. Race science rationalized chattel slavery, and diagnosis and disabilities were created to pathologize such things as an enslaved person desire not to be enslaved. Women everywhere were deemed inferior to men based on science that claimed them emotionally childlike, of inferior intellect to men, and better suited to domestic life, or if part of the workforce, paid lower wages. In Canada, immigration laws were very specific about excluding those with physical and mental disabilities. Charles Darwin's theory of evolution inspired his cousin Francis Galton to use the appearance of science to construct the theory of eugenics, which was eagerly adopted by many progressive thinkers at the time, including famous Canadian suffragettes Nellie McClung and Emily Murphy, as well as the father of Canadian healthcare himself, Tommy Douglas. Eventually, eugenics was adopted by the Nazis to rationalize the Holocaust, which began with the mass murder of disabled children and adults. I always find it interesting that the famous poem about First They Came For neglects to mention who they came for first: disabled people. Throughout the time of mass institutionalization, forced sterilization, and segregated lives for disabled people, cities, schools, institutions, and policies were built. Today, the legacy informs our concept of the correct or standard way to design everything and policy, and determines our framework for understanding what is normal and good. But that was never the only history that was happening, though it is too often the only history that gets recorded and told. If we draw a line and title this part "The Oppression," parallel to this was and is anti-oppression. Next slide. Every single right we have has been fought for. Curb cuts exist because some disabled people literally took sledgehammers and bags of cement out and started making them. Decades later, when I was appointed to an advisory council for the city of Vancouver, I discovered 8,000 of the city's 27,000 corners still do not have curb cuts. The projected date of completion was 200 years. I wrote a motion. It passed. Nothing changed. Next slide. We have accessible buses because disabled people lay down in front of the inaccessible versions. Next slide. Some of us live in the community because disabled people fought for our right to be able to. I had to fight for that right in 2009. I was informed I could not live in an apartment in the community and would need to move into a nursing home, decades before anyone in Canada would expect to. The nursing home was offered after they were unsuccessful at trying to force me to sign a DNR. The hospital employee brought the DNR to my bedside along with a box of tissues. She had heard that my boyfriend had left and that I was going to lose my apartment. She said she felt badly for me and that I had been through so much I deserved rest. When I refused to sign the DNR, she became annoyed. I was non-compliant, a bad patient, failing to take the advice I was being given. I don't understand why you would even want to go on living, she exclaimed. Disabled people are still fighting. We fight for bathrooms to pee in and housing to live in, and every fight is another knife because the essence of all of these things is the same. Stop excluding us from your definition of human. We are in the earliest of stages of this struggle. It would be easy to look at the people in the first slide and assume victory has been achieved. But let me tell you something else about the people in this photo. They all carry trauma. They face struggles and barriers they should not have to. They all have heard they'd be better off dead, and they all have been lucky enough to have some people who value them. Most of family support. The majority of disabled people living in poverty live alone or are single parents. Family support should not be the deal breaker, it is but the safety net in our country is a few strings strung across a wide open and very deep pit. But even having family is no guarantee. Tracy Latimer had a family. Her father murdered her. Public sympathy for the child murderer was so great that it is widely considered to have played a role in the passing of the original MAID legislation. The murder of a disabled child whose father was an anti-science-based medicine extremist and who cites Tracy's need for hip surgery as what made him decide to kill her, is part of why we are here today. So how do I feel about Bill C=7? I feel like the discussion about choice needs to be grounded in the history and current reality of disabled people, and it is not. I feel like I'm being given a VIP pass to death or the option of an endless series of nearly or completely insurmountable barriers that will inflict further and unique trauma and harm on me for daring to wanting to live. I feel like the right to live needs to be more than words on paper. I feel like we should address the structural oppression of disabled people in Canada. I won the fight to live in the community but not the right to physiotherapy. I am given sufficient funds to not starve but not sufficient to buy incontinence garments, medications and equipment that is not covered, a haircut or new underwear. I live in spite of being made to feel I am take up too much space, require too much care, cost too much, contribute too little, am a burden and a waste. I swallow and I go on spite of everything and everyone that tells me not to because I am defiant and I surround myself with fighters. People who support Bill C-7 claim it about choice. What choice is that exactly? Imagine this scenario. A country declares people have the right to vote, but there is only one poll and it is only open for 1 hour on one day. Do you really have the right to vote? Or does that right require the material means to be created to make it possible?
Thank you, Gabrielle. That was amazing. I know we're at the end of our time. So Dr.
Just 1 minute, Ramona, a couple things. Number one is we can go till 9.